All right, so we're going to talk about our tutoring for the PTSD, trauma, stress, anxiety, and then substance use disorders. So first we have our defense mechanisms, and these can be reversible, and the client is going to use them in either an adaptive or a maladaptive manner. Adaptive is going to be when we use our defense mechanisms to help others and ourselves to achieve their goals, and this is an acceptable way, and it also helps us reduce our anxiety. Defense mechanisms become maladaptive when they interfere with normal functioning, relationships, orientation to reality, and are used in excess. So here you have the answer key to our matching worksheet that was in your packet. So you can go ahead and take a look at these and see what you got right, and if you need to take a look at anything else. As far as anxiety goes, we have our normal anxiety, which is our healthy life force that works for our survival and motivates us to act. Then there is acute anxiety, which is an imminent loss or change that threatens your security. You can then have chronic anxiety, which develops over time, starts in childhood, and your anxiety is going to display physical manifestations, and the biggest piece of this is that it works over a long period of time. So our nursing actions for anxiety work very similar to our crisis. For our mild and moderate, we're going to use active listening, calm presence, recognize the client's distress, see what kind of coping mechanisms work for them, and see if we can explore alternative solutions and problems, and encourage activities such as exercise that might help release some of that anxiety. When our anxiety is in severe or panic level, at this point, we need to provide an environment that is physically and emotionally safe. So it meets the physical and safety environment needs of the client. We're going to stay with the client and remain calm, and we're going to provide a quiet environment with limited stimulation. So as we kind of talked for the last exam, sometimes we have to force them into an area with limited stimulation because they can't do it themselves, and staying where they're at is a worse situation for them. We will do things like encourage gross motor activities such as walking, running, anything like that. We're going to have to set limits using firm, short, simple statements. And during this time, like we said, we need firm and concise and concrete. We don't need a bunch of ups and downs, left and rights, this or that. Just firm and straight. These are our options. Point, blank, and blank. Looking at our trauma and stress-related disorders, we have our acute stress disorder, which is our exposure to a traumatic event that may cause anxiety, detachment, and other manifestations for about 3 days, but not longer than a month. PTSD, post-traumatic stress disorder, is going to be pretty much the same thing, except for it lasts longer than a month following the event and can manifest up to 3 months after the event, and then it can last for years to come. Then we have our adjustment disorder. This is a stressor a stressor triggers a reaction causing a change in mood, dysfunction, inability to regulate. We can't perform our usual activities, but it is typically less severe than with the other two. Another one that we may see, especially with an abuse and neglect in children, is going to be our reactive attachment disorder. This is a condition where a child doesn't form healthy emotional bonds with their caregiver, and therefore they cannot develop healthy bonds with anybody who comes in their life or helps take care of them. And then we have OCD, or obsessive compulsive disorder, which is where we have a repetitive, rule conscious behavior that interferes with daily living and functioning. Aside from that, we need to know that the goal of an OCD, that the goal of the compulsion is to decrease one's anxiety. So now we have different reactions to trauma. So most people know fight or flight. So flight is going to be that increased heart rate, muscle tension, and we use this extra adrenaline to run away from the situation. Fight being that same thing, that same adrenaline charged through our body, but we use it to fight whatever is causing us stress. So another two that people, this happens, we don't talk about as much, but there are two others. One is called a freeze reaction. So this is where you become overwhelmed by the memory or the traumatic event, and it causes the thinking center of your brain to essentially shut down and not process information. You truly just stop and freeze and cannot move, cannot talk, cannot process. And then lastly, we have fawn. This is when the client sets aside their needs, becomes emotionally numb, and wants to avoid conflict and trauma by appeasing the people who inflict trauma. We have our historical trauma. Historical is going to result from a trauma or adversity that's been passed down through generations. Vicarious, so experiencing a trauma, experiencing going through a trauma by engaging with survivors. So if you ever hear of somebody, your parents live vicariously through you, so through another person, this is where we work with, especially as healthcare workers, we work with so many patients who deal with trauma, and we end up taking it onto our own. Then, of course, we have acute and chronic, where acute occurs after a single exposure to a trauma, and chronic is multiple persistent traumatic events that happen over a period of time. So now we have dissociative disorders. These disorders are going to be characterized by a temporary change in awareness. So we have depersonalization. This is our out-of-body experience. We have derealization, which is the feeling that events are unreal, part of a dream, or maybe objects are larger or smaller than they appear. That can be called Alice in Wonderland syndrome. Remember, she eats the mushroom and things get bigger, things get smaller, things like that. We have dissociative amnesia, which is the inability to recall personal information related to a traumatic or stressful event. And this can be of the entire traumatic period or just certain details. And then lastly, we have dissociative identity disorder. Dissociative identity disorder used to be called multiple personality disorder. Client displays more than one distinct personality, with stressful events participating the change in one's personality to another. This can also occur due to that fawn response, and we'll talk about that a little more in class as well. All right, so let's talk about our medications. So for our stress and anxiety, the two main meds I need to know are benzodiazepines and buspirone. So our benzodiazepines typically end in PAM and LAM, except for one that we talk about for substance use disorder. There's another one that is more long acting, and I talk about that more in the substance use. But yes, most of them end in LAM and PAM. They are habit forming and they're used PRN. They should not be taken regularly. But if our patient has been taking their orzolazepam, their diazepam or alprazolam for the last 6 months every night before bed, we do not want to take them off of it because they will withdraw and cause those withdrawal effects. So if we have that, we're going to want to go ahead and give them that benzo, and then we can discuss tapering down or off. Of course, we want to avoid anything that decreases our CNS symptoms because these are going to cause CNS depression and can cause respiratory depression. And if that does happen, we have a toxicity or an overdose. Our antidote is flumazenil. As far as buspirone goes, this is non-habit forming, but has to be taken regularly and every day, not just as needed. And we will need to avoid grapefruit juice. You will see results in about 4 to 6 weeks, so it's not immediate like the benzos. And we are at risk for serotonin syndrome. So remember, serotonin syndrome is that sweaty diaphoresis, tachycardia, increased blood pressure, tremors, fever, and all of this can lead to coma and death. And then as you flip through the pages before, I inserted some drug cards from ATI and then just the little inserts that I have for everything else. All right, moving on to somatic disorders. Somatation is going to be the expression of psychological stress through physical manifestations. These physical manifestations cannot be explained by an underlying pathology or cause. With somatic symptom disorder, we are going to have a patient who spends significant time worrying about their physical manifestations. They probably will reject a psychological diagnosis and may seek care from multiple providers. Our illness anxiety disorder is an anxiety that the client has in a serious illness or is going to get one. This anxiety is for 6 months or more, but throughout the session of this 6 months, the type of illness the client fears can change. So they might have 2 months where they think they have breast cancer, and then 2 months where they think they're having a brain aneurysm, and then another 3 months where they think they're having a stroke. And that still all encompasses that one. We're going to have a preoccupation with health-related behaviors like self-breast exams, wanting a bunch of diagnostic testing, things like that. We can have a form that is health-seeking, meaning they try to go to the doctor for everything, get every scan under the sun. Or we have care avoidant, which is where they avoid going to the doctor, going to get checked out for anything because they're scared something bad will come back. Next, we have conversion disorder. This is going to be neurological manifestations without a neurological diagnosis. We will typically see deficits in our voluntary motor and sensory functions, so things like blindness, paralysis, seizures, gait, hearing loss. things like that. And then we have factitious disorder. Factitious disorder used to be Munchausen's. It is the conscious decision to report physical and psychological manifestations without a personal gain except for the emotional need of attention. Sometimes the clients will inflict self-injury. Same process can occur with factitious disorder on another person, which used to be Munchausen's by proxy. This is where the caregiver of somebody does this to the person that they're caring for. Again, for attention. If this is done for any reason outside of the attention emotional needs being met, like if it's done for money or time off work or anything like that, that is called malingering. All right, so now we have our alcohol use disorders, looking at our signs and symptoms of alcohol withdrawal.